Welcome to today's webinar, Simplifying Antiretroviral Therapy, 2 Drug Regimens and Long-Acting Treatment. I'd like to introduce Joseph J. Eron, Jr., MD, from the University of North Carolina at Chapel Hill. Welcome, Dr. Eron.
Welcome, thank you. Okay. Sorry, I'm muting my own echo. Just a few notes before we get into the meat of the presentation. You do have to update your account if you haven't logged in recently, and that's what this slide talks about. There is CME credit. There are 1.25 credits for AMA. In addition, there are nursing credits and pharmacy credits and pharmacotherapy credits. And the information is on the slide that's on your screen right now. You will be able to evaluate this program. The evaluations will be available in your IAS-USA My Activity page by 5 p.m. Pacific Standard Time today. Generous support for this activity has been received from the following contributors. And when we're navigating, a separate question shows up just like this. A separate question will show up with the polling questions. You choose your response from the poll, so not in the chat box, but in the poll. And then responses will be displayed once the poll closes. However, if you do have questions, those questions are actually typed into the chat box. So here's our first question. So go ahead and vote. Okay. I'm hoping that you can see the results of the poll. We're just basically people from all over the U.S., mostly the Northeast and Southeast, but also about 20% from the Western United States. So really people from all over, a couple of folks from Canada, Mexico, and even some Europeans who are up late. Great. Thank you. Then our next question. So this is asking you when the results will be available. So I told you when they'll be available. This is a nice reminder. This is when the evaluation will be available on your My Activities page. Great. So you can see that everybody, 90% of you got it right. The evaluation will be available by 5 p.m. Pacific time, so 8 p.m. Eastern time on your My Activities page. All right, now we can move on. And then this is our third question. I want you to just rate your level of expertise in HIV, with 5 being an expert and 1 being a novice. This is not about how many patients you see. It's kind of your confidence in your level of expertise. So go ahead and vote. All right, so we have a pretty expert group. More than 2/3 have said they're either a 3 or a 4 in terms of expertise, and a few people are a 5. Those are probably people that should be giving the talk. I appreciate that. And there are a few people that are novice or earlier in their HIV treatment careers, and hopefully I can provide you with some data and information that will help you. Okay, let's keep going. So I'm going to talk about, give you a bit of a general overview of HIV management, but really focus down on 2 drug treatment regimens and then long-acting therapy. These are my potential conflicts and financial relationships with commercial entities, updated recently. These are our learning objectives. So what I'm hoping to do is describe the clinical information needed when contemplating an HIV regimen simplification in people living with HIV who are suppressed on therapy. I'm going to hopefully make it so that you can list potential advantages and disadvantages of 2-drug therapy, both for people who are starting therapy and for people who are switching. The learning objective talks about switching. And then when this talk is over, hopefully you'll be able to summarize the results of the phase 3 studies of the long-acting antiretroviral therapy. So these are our pre-test questions. You're not going to see the correct answer here. So the first pre-test question, which of the following is a potential advantage of 2-drug dolutegravir lamivudine therapy that is supported by comparative clinical trials? So you don't need to know the answer. Hopefully you're going to learn the answer here during the talk, but go ahead and give us your input. The goal is to teach you all something. So you all are pretty smart. So. And I encourage everybody to vote. Even if you don't know, it's fine. The goal is really to get to the point where you learn something from the presentation. So please don't feel shy about voting. Go ahead and vote. Terrific. Okay, our second pretest question is which statement below most accurately summarizes the results of the phase 3 studies of cabotegravir plus rilpivirine long-acting therapy? So choice A is cabotegravir rilpivirine long-acting was inferior to continued oral therapy. Choice B was cab rilpivirine long-acting was non-inferior to continued oral therapy, but there was discontinuation due to treatment injection site reactions up to greater than 5%. C is the combination long-acting was non-inferior to oral therapy, and discontinuation due to injection site reactions was uncommon, but HIV resistance emerged in a small number of patients. And then choice D, cab rilpivirine was superior to continued oral therapy, but patient satisfaction was poor. Okay, great. We can see who answered what. We should probably move on. Okay. First of all, just to level set, these are the goals of antiretroviral therapy. I think people are all aware of these. Our desire is to maintain and restore the health of people living with HIV. We want to minimize short and long-term adverse events. We want to make sure that therapy is accessible to all people, and I think that's part of the reason why we're going to be talking about 2-drug therapy and long-acting therapy. And then, of course, we also want to prevent transmission, though we won't be talking about that in this talk. So So there are trends in care, and I'm focusing mostly on first world or developing world setting. So our goal is to get to 90-90-90, but I think all of us who are HIV caregivers know the last 10% in each of those categories are really the most challenging. Those people that are newly diagnosed are more likely to be disenfranchised, more likely to have kind of mental health and substance use comorbidities, may be most impacted by stigma, both external but also internal stigma. And in the U.S., we have this growing intersection of the opioid epidemic and HIV. And I think it really is critical that we have therapy that is available to all different types of people in order to get beyond 90-90-90. And fortunately, I think patients with limited treatment options are uncommon. So I think one of the things we can probably all agree on is that integrase inhibitor-based therapy will be the anchor of HIV treatment for both first and second-line regimens. And I think probably everyone here knows that our guidelines, both our DHHS and IAS-USA guidelines, are focused 100% on integrase inhibitor-based therapy. This is for initial therapy. And there are a couple of changes recently, and one is that we no longer recommend agents that require boosting as initial therapy. So Bictegravir as a first-line integrase inhibitor is not on the list. And then you can see that Dolutegravir 3TC now has made it onto the DHHS guidelines based on some of the studies I will show you in a little bit. That's two-drug therapy as a preferred regimen. Now, there are some caveats on the DHHS guidelines. It's recommended for people with HIV RNAs less than 500,000 copies at screening, so that's important. Remember that. People cannot have active hepatitis B infection, and the guidelines are recommending that a genotype resistance test be available prior to starting. The IAS-USA guidelines don't include Dolutegravir 3TC yet, but as people probably know, the guidelines are published every 2 years from IAS-USA, and I'm quite confident that we'll be discussing Dolutegravir 3TC as part of our IAS-USA guidelines coming up. And I don't know whether they'll reach preferred status or recommended status, but they certainly will be discussed extensively, that combination. There are many, many studies now that show that first-line integrase inhibitors are either non-inferior or superior to alternatives. And I'll just focus you on the last line in the column. These are the Gemini studies, which I'll go over. These studies compare Dolutegravir 3TC, this again is initial therapy, with Dolutegravir plus TDF-FTC, and the result was clearly non-inferior. We know from studies 1489 and 1490 that Dolutegravir with 2 nucleosides and Bictegravir with 2 nucleosides are really virtually identical in terms of their treatment outcomes. So many of our new first-line patients are starting either Bictegravir or Dolutegravir-based therapy. So here's the Gemini study. So the Gemini was actually 2 studies. These were treatment-naive patients, viral loads at screening less than 500,000. They couldn't have hepatitis B, and they couldn't have resistance to either 3TC or integrase inhibitors. And really what you can see over 96 weeks now, the curves for the 2-drug therapy versus the 3-drug therapy. So the 2-drug is in that greenish color, and the excuse me, the 3-drug is in the orangish color, and you can see that really they're virtually identical over time. Now, these are results that that were presented a year ago. This is actually looking at the baseline viral load in patients who were in the Gemini study. Remember, these are two large studies, so there were almost 700 individuals who were randomized, just over 600 individuals that were randomized in each treatment arm. And what you can see is you go up. I'm going to try to get my pointer back, sorry. Here it is. As you go up the viral load scale, there really is no difference. Again, now 3TC dolutegravir is in the dark blue, the 3-drug therapy is in the light blue. You might ask, well, how did you get some people that were greater than 500,000? This is the baseline value, so at screening they were less than 500,000. At baseline they were above 500,000. These numbers are really small, 15 and 13 in each group, so there's not a lot of weight to this evidence, though I think that there really is no notion over time that the 2-drug therapy is having less activity than the 3-drug therapy as the viral load increases. And I think probably significantly and importantly, there were no virologic failures with resistance in the 2-drug therapy arm or in the 3-drug therapy arm. So this slide here looks at multiple different integrase inhibitor-based therapies using a second, what we would call a second-generation integrase, Dolutegravir or Bictegravir. Some of them are comparisons. This is Dolutegravir compared to Raltegravir or Dolutegravir compared to efavirenz. These are the Dolutegravir Bictegravir studies I mentioned, and then finally Gemini 1 and 2, which is here. And what you can see is that in no study of a second-generation integrase inhibitor, no study of a second-generation integrase inhibitor has there been emergence of resistance in a phase 3 study. The one caveat is in the earlier phase 2 study of Dolutegravir 3TC, a smaller study of 120 patients, there was one patient that developed resistance. But for the most part, second-generation integrase inhibitors in the treatment-naive setting, very, very unlikely for there to be selection of resistance. Not impossible, because there are some case reports, but extremely unlikely. And you might ask, well, what if there's baseline resistance and we don't know about it? So this is one of the studies. These are from the 1489 and 1490 studies. This is looking at treatment response to Bictegravir, FTC TAF, and they looked at pre-existing resistance mutations. The blue line is total. The red line is there actually were a few patients that snuck in with integrase resistance, primary integrase resistance, many that had secondary resistance mutations, which basically aren't important. Some had nucleoside resistance, some had NNRTI resistance, actually almost 10%, which is not that surprising. And then a few had PI resistance, and basically it really didn't matter what your baseline resistance was. You were very likely to be suppressed, very unlikely to have a detectable viral load, and very few of these patients actually even had enough virus present to have resistance analysis, and of course none developed resistance. And you might guess what manufacturer presented these data, because obviously the study also studied Dolutegravir plus 2 nucleosides, and the overall results were non-inferior, so I suspect you would find the same results for Dolutegravir if they were presented. And we know that integrase inhibitors are well tolerated, and people tend not to discontinue. These are data from our cohort here at UNC. But there may be some reasons to worry about integrase inhibitors, and people may have questions about that. And there may be some reasons to worry about integrase inhibitors plus TAF. TAF-based regimens. Well, what about transmitted integrase resistance? How common is that? What about women of childbearing potential? Many people have probably heard about the observation of neural tube defects in the Suppression study in Botswana. There's now, I think, fear of fat. I think it's pretty clear that some of our patients, when they go on integrase inhibitors, perhaps plus TAF, have substantial weight gain. Is that something to worry about? There may be an impact of generics and cost, and this where two-drug therapy may come in. And, well, is there effective non-integrase therapy? And that's an important question. So transmitted drug resistance to integrase is very uncommon. This is from our group here at UNC, where we looked at 800 patients living with HIV who had resistance testing within 3 months of diagnosis, and 2 had evidence of transmitted integrase inhibitor resistance. So well under the 1% that Paul Sachs and others have said would be necessary to make resistance testing necessary. And I might point out that both of these patients would likely have been sensitive to Dolutegravir or Bictegravir in terms of resistance, phenotypic resistance testing. This is the Suppression study. You might remember that over a year ago there was some concern that perhaps as many as 1% of pregnant women exposed to Dolutegravir in very early in pregnancy might have neurotube defects. The confidence interval was the initial report was almost 1%. The follow-up study, having a larger number of women, actually showed a lower estimated percentage of 0.3%, so 3 in 1,000, but still relatively large confidence intervals, and it's obviously greater than about 1 in 1,000, which we see with other ART. And if you look at Dolutegravir later in pregnancy, there actually were no neurotube defects. So there's some question about folate supplementation and how important that might be. And our advice to women in terms of use of Dolutegravir in women who are considering pregnancy has changed. These are new DHHS guidelines. Providers are instructed to discuss the benefits of using Dolutegravir and the risk, and noting that it's probably higher than with some other antiretrovirals, but lower, but still quite low, and it may be considered as an alternate. And then, of course, for individuals using effective contraception, Dolutegravir may be used as a recommended option. And again, I'm stressing this need for folate replacement in women who are folate supplementation, in women who are pregnant. And what about fat? So these are the studies that are published last summer in the New England Journal. This is the ADVANCE study, which was done exclusively in South Africa. This is looking at Dolutegravir FTC TAF. That's the blue line, which I'm going to focus on. Over a 2-year period, men on average gained 10 kilograms. Women on average gained, men gained 5 kilograms, which is about 12 pounds. Women gained on average, remember this is average, 10 kilograms, which is 22 pounds, compared to 5 kilograms with Dolutegravir FTC TAF and only 3 kilograms with efavirenz FTC TDF. So this is Dolutegravir FTC TDF. This is efavirenz FTC TDF. So again, there's this concern or issue related to weight gain, especially with second-generation integrase inhibitors plus TAF. And Paul Sachs and his colleagues published a paper in CID just a few months ago showing that basically if you compare Dolutegravir with Bictegravir, weight gain is almost exactly the same, and I would urge you to take a look at that paper. These are some alternatives to initial integrase inhibitor therapy. I'm not going to go through these. We do wonder whether any of these will have less impact on weight gain. We know for sure that efavirenz TDF-FTC has less impact on weight gain, and actually is one of our safest drugs in pregnancy, which is always based on those of us who have been doing this for a long time, is almost funny to say, and can be used with TB and with hepatitis B, but still not a recommended first-line therapy for most patients. Our newest therapy is Doravirine, which can be given with either TAF-FTC or TDF-FTC, though it's been studied predominantly with TDF-FTC. It has advantages over rilpivirine. It's once daily. There's no PPI interaction. There's no food restrictions, though it has some disadvantage in that it's obviously not combined with TAF in its fixed-dose formulation. And when we look at the studies, Doravirine just doesn't hit the same mark as our integrase inhibitors. Here's 48 weeks. This is a combined analysis of the two phase 3 studies of Doravirine as initial therapy. You can see in light green that it does very similar to the comparators. One is efavirenz, the other is darunavir ritonavir, but is still around 6 to 8% lower than what we see with integrase inhibitors. This is not a head-to-head comparison. You have to be careful comparing across studies. On the other hand, I think that we've seen this before with NNRTI, where they're really in the 80 to 85% range, not the 90% range. So I think, and there is some risk of resistance in virologic failure on Doravirine. These are the resistance data. In this data set with Doravirine, over 700 individuals got Doravirine as first-line therapy, and they developed primary NNRTI resistance 7. So 7 out of 700, that's 1%. That's an easy calculation. They typically had two-drug resistance, two-class resistance, both Doravirine and nucleosides. Clearly lower than with efavirenz, 3% versus 1%, but still there is some risk of resistance. So let's talk about, will two-drug Dolutegravir 3TC be used commonly for initial therapy? So these are my thoughts. They're nobody's thoughts but mine. I think for three-drug therapy, I hear this a lot. If it's not broke, don't fix it. TAF is so safe. Why don't I just make sure it's okay? What's the harm of using 3 drugs for a year or 6 months and then going to 2 drugs? If I think, those have some legitimacy to the argument, except that you wouldn't use 3 antihypertensives if you only needed 2, or 3 lipid-lowering agents, or 2 lipid-lowering agents if you only needed 1. But I think for people, again, who have been doing this for a long time, like me, 3 drugs is what we kind of grew up on and realized that was the optimal combination, at least up until now. So I think there will be persistence of 3-drug initial therapy, and for other reasons. I think for rapid start and acute infection where you don't have resistance testing, you don't have hepatitis B testing, I think treatment patterns are hard to change, especially when there's little efficacy difference, little safety difference, and as yet little financial pressure. I think if there's more financial pressure towards a 2-drug regimen, then I think that will change how we practice. Obviously, if they have hepatitis B co-infection, you should use a tenofovir-based therapy if at all possible, and if you can't, you should use enfuvirtide. Baraclude or Integrase. And then again, while the package insert doesn't say anything about greater than 500,000, the DHHS guidelines do. There's an open question whether this fat gain might be less with Dolutegravir plus 3TC compared to Dolutegravir plus TAF-FTC. We don't know those data yet. And then when we get two drugs into widespread clinical practice, we'll pay attention to supports of emerging resistance. Again, in the clinical studies, if you look at phase 2 and phase 3, with almost 1,000, actually over 1,000 patients studied, we haven't seen emergence of resistance except in one case of a very poorly adherent participant. Okay, well, what about switching therapy in suppressed patients? This is kind of how I think about it, which is that individual patients should be on the simplest, safest therapy that best fits in their lives. And probably for most people that's once a day, but maybe not everybody. For some people that may be a long-acting injectable, which we're going to get to in a little bit. This is a slide that I got from one of my colleagues, Joel Gallant, and he thinks about horizontal switches, and what he means by that is when you switch essentially in the same drug class, like ritonavir to cobicistat, or efavirenz or nevirapine to rilpivirine or doravirine, or between protease inhibitors, or between nucleosides, or from TDF to TAF. Those are pretty safe and can be done almost in anyone. These are kind of vertical switches is the term he uses. I think of switching a drug to another with a lower resistance barrier. So if you have a patient on a complex regimen and you think, well, maybe they don't need all those drugs, so I'll just stop one. That would be a kind of a vertical switch. You know, perhaps people are on more nucleosides than they needed to be because we did that in the past. Or maybe they don't actually really need a boosted PI. Going from a boosted PI to an NNRTI would be considered a lower resistance barrier. This one's a little bit of an argument. Going to a boosted PI to an Integrase, if it's Dolutegravir or Bictegravir, is that really a decrease in resistance barrier? Maybe. Maybe PIs have a slightly higher resistance barrier, but there's no real data to argue that point. It's an opinion. And then finally, if you have a patient on twice daily darunavir, ritonavir, and you want to go to once daily. So these vertical switches or switches to a lower resistance barrier really have to be done very carefully, where you try to get all the resistance data possible that you can, and the treatment history data that you can, so that you can have some sense of whether there's resistance kind of lurking in the background. And I think all of us have examples of patients who have switched off to a boosted PI when they're on just a boosted PI and 2 nukes, and went on to either a first-generation Integrase or a first-generation NNRTI-based regimen, and then had rebound. At least I've had that experience, and so getting a careful history here and doing this may be a circumstance where some clinicians would consider an archive genotype, so a genotype looking at DNA, not at RNA. One thing for sure, if you look at clinical studies, most switch clinical studies are very successful, in part because the designers of these studies, the pharmaceutical companies, don't want to design risky studies. They want to design studies that simplify therapy or make it easier to take or have fewer side effects, and they want them to be successful, and they're pretty good at that. So I'm not going to read through all these. You can find many, many, many switch studies that were successful. And they're usually done very carefully. So what about switches to 2-drug therapy from 3-drug therapy? So this is the SWORD study. This was a switch from 3-drug therapy. These were people who are on stable NRTI, Integrase, or boosted PI regimens with 2 nukes, so 3-drug therapy. they had to have suppressed viral load, and they couldn't have previous virologic failure, and of course they couldn't have hepatitis B infection active, and they couldn't have any known resistance to dolutegravir or rilpivirine. And the bottom line is this is very successful. This is now over 1,000 patients who have switched, some earlier, some later, and very excellent results with this particular combination. And there have only been 10 patients, at least at this 148-week time point, 10 out of 1,000 patients, so again 1%, that developed resistance, and they developed NNRTI resistance, not integrase resistance. Here you do have the issues of rilpivirine in terms of the food and PPI disadvantages, but this is certainly a combination that can be used in patients who are suppressed to maintain suppression. This is the resistance analysis. As I mentioned, there are 10 confirmed virologic failures. So I misspoke, 10 confirmed virologic failures, and only 3 individuals that developed NNRTI resistance. So 3 out of almost 1,000 that developed NNRTI resistance. And one of the 3 actually at baseline using the archive genotype test actually had integrase resistance to start with. And we didn't see any, sorry, I'll go slower. They had NNRTI resistance at baseline by the archive test. And in these 3 patients, 2 of the 3 were able to be genotyped. Neither had integrase resistance. So you might ask, well, what about dolutegravir 3TC as a suppressive therapy and as a continued suppression in patients who are already suppressed? And so this study focused specifically on patients on a TAF-based regimen. So these were adults. They had to have a viral load less than 50 for at least 6 months, and they were on a stable TAF-based ART. So obviously it was FTC TAF because that's how you get it, and they could be on a PI, NNRTI, or an integrase. They could have been on TDF in the past, but they had to switch to TAF within greater than 3 months. And they were randomized to either continue on their TAF-based therapy or switch to dolutegravir 3TC. And this past summer at IAS, we saw the results of this study. And basically the results were very, very comparable. I don't think you can get them more comparable. Blue is dolutegravir 3TC. Red is continued TAF-based therapy. There's no difference here. There was 0.03, which is 1 person that actually had HIV RNA greater than 50 copies after entry. And that's a patient who actually left his, that's a single patient. For the 3-drug arm, I think there were a couple patients that had detectable viral load. No patient was genotyped. No patient had resistance. There were a few patients that had the M184V mutation at baseline using proviral DNA, and those people remain suppressed. And you can see, obviously, that there's no difference. They're non-inferior, and if they decided to have an equivalence endpoint, they would have gotten it based on our definition of most people's definition of equivalence, which is plus or minus 4%. So very successful, well-tolerated therapy. We also know that if you look at people who are suppressed on dolutegravir FTC TAF and have previous virologic failures, so these are patients where a allowed in that had previous virologic failure, though they couldn't have had previous failure on an integrase. These people stay suppressed on a TAF-based regimen, but they were already suppressed on a dolutegravir-based regimen. So I'm going to skip through that. Okay. Well, why don't we take a break for a second? If people want to ask a few questions, you can type them in and ask them. So one of the questions that comes up, they're asking me if I'm switching patients who are well controlled but not having any side effects on a boosted integrase inhibitor regimen. And I would say yes, in general I am switching those patients. There might be an exception. And certainly in my practice, many of my patients have kind of multiple care providers, unfortunately, for not for their HIV, but for their other illness. They unfortunately end up in emergency rooms for other reasons. And I worry about unnecessary drug-drug interactions that you see with the booster. Also, there are over-the-counter medications. The classical one is St. John's wort, but there are others that have drug interactions with cobicistat. So I think, and I've seen multiple patients on topical, meaning inhaled fluticasone, or that have had changes in their glucose control, for example, if they're diabetic, because they got an inhaled steroid. And I've had one patient who got an injectable triamcinolone for knee arthritis that developed frank hyperglycemia related to the systemic exposure from injected triamcinolone. So I do switch people. So now there's another question along the similar lines. If someone has been on efavirenz, TDF-FTC, and undetectable for years with no side effects and no underlying medical problems, would you switch? You know, maybe a year ago I would have said yes, probably. Now, I mean, if they're really perfectly fine, I think there now is some risk of weight gain if you switch to either dolutegravir or bictegravir TAF-based therapy. I do think over decades, TAF is probably safer than TDF. I think everybody knows the data. Certainly the impact on bone density is less, and the impact on proteinuria is less, and there are fewer cases of frank renal dysfunction if you look at larger populations on TAF, obviously versus TDF. Obviously those are less common with TDF and efavirenz because there is less of a drug interaction than TDF with boosted PIs. So I would take that one on a case-by-case basis. Okay, a question which is a great one. With M184V mutations or multiple minor variations, are you still comfortable with two-drug regimen only? I would be very comfortable with dolutegravir rilpivirine, but I don't think that's what you're asking. I think you're asking would I be comfortable with dolutegravir and 3TC. If I knew the person had M184V, I would not use dolutegravir 3TC. How's that for a declarative answer? There are data. There's an Italian study. People are looking at archived DNA that seems to show that people can stay suppressed even if they have archived M184V and dolutegravir 3TC. But I feel like that's not a risk I need to take because that's a relative minority of patients. I wouldn't go looking for M184V, but and I certainly wouldn't give a viremic patient with M184V, dolutegravir, and 3TC. Then a nice question: do I switch Triumeq to dolutegravir bacavir 3TC to dolutegravir 3TC in a well-controlled patient? Absolutely, 100%. To be honest, it was on one of my earlier slides, but I don't really see a real reason to use abacavir in anyone. But that's my personal opinion. That's not a guideline. But I don't think there's a real indication for Abacavir. Abacavir has, if someone's on Abacavir 3TC, Dolutegravir, they probably don't have a majority variant in their background with M184V. Maybe they have some variants with defective viruses with 184V, but I would feel very comfortable with that switch. All right. I will answer some of these other questions, but I think this was a good break for people to maybe solidify their knowledge base, is what Donna Jacobson says we should be doing here. So hopefully I've solidified some of that. Okay, so now I'm going to talk about long-acting injectable therapy. In parentheses, I feel like there'll be relatively slow uptake. That I wasn't really predicting that the FDA would make the uptake even slower. So just to start out, probably everyone knows, but if you don't, the long-acting therapy I'm going to talk about is Bictegravir, long-acting, plus Rilpivirine, long-acting, as an injectable. And there have been studies of once-monthly injections and 2-monthly injections, or every 4-week injections, every 8-week injections, and that was submitted to the FDA with a decision deadline date of I think December 29th or something. But on December 21st, the FDA actually said that they're not going to approve the Bictegravir long-acting, Rilpivirine long-acting with the current information. And what we know is that it was not safety information or outcome information. We know that it had to do with kind of formulation and actual chemistry of the formulation that would be used in the commercial product. What we don't know is how long it will take ViiV Healthcare, and I'm just saying that because that is the sponsor, I think that's common knowledge, how long it will take for them to address the FDA comments, and then how long it will take the FDA to decide whether the comments are addressed. We know, based on letters to investigators, that there are actually no safety issues for people that are on Bictegravir, Rilpivirine, long-acting in the context of clinical studies. We also know that ViiV Healthcare has stated unequivocally that they are going to address the FDA comments. That FDA letter, in my understanding, is a confidential document. I certainly don't have access to it. I don't think anybody outside ViiV and the FDA have access to it. People can ask me questions about it, but I just told you just about everything I know. But I'm happy to, we can talk about it when this section is over in 12 minutes. So there were 2 studies of the combination Rilpivirine. I'm going to say Rilpivirine. I think you guys are all going to know it's long-acting. There were 2 studies. One was Atlas. In Atlas, these were, let me get my pointer back. I lost it. Here we go. Oh, maybe not. Here we go. There it is. These were individuals who were suppressed relatively long-term. Actually, it had to be more than 6 months, but most people were much longer than that. And they were randomized to either continue on their baseline oral therapy or switch to Bictegravir, Rilpivirine. The way that switch works, at least in the phase 3 studies, is patients needed to go on oral Bictegravir, Rilpivirine for 4 weeks and then be switched to the injectable. So when it's monthly injectable, it's 400 milligrams of Bictegravir and 600 milligrams of Rilpivirine every 4 weeks. I keep saying monthly, but it's every 4 weeks. This is 2 mLs and 2 mLs. So it's 4 mLs injected into the gluteus medius, which is basically back there somewhere. And so that's the ATLAS study, and there's a 48-week primary endpoint, which I'll show you in a second. The FLAIR study was slightly different. The FLAIR study started with ART-naive participants that had to have a viral load greater than 1,000 copies. They had to be hepatitis B surface antigen negative, as did these people up here in ATLAS, which I forgot to mention. They had to have no NNRTI RAMs, except 103N was permitted. So 103N transmitted drug resistance was allowed. Patients went on to Dolutegravir, Bictegravir, 3TC fixed dose combination for 20 weeks. Those who were suppressed at 20 weeks were randomized to either stay on Dolutegravir, Bictegravir, 3TC, or again get randomized to first 4 weeks of oral CAB, rilpivirine, and then injectable CAB, rilpivirine. Same doses, of course. This has a 48-week primary endpoint, but will be ongoing to 96 weeks, which hopefully we'll see those results soon. I'm showing you the ATLAS results, but the FLAIR results are almost the same. Blue is the injectable, red is continued oral therapy, and what you can see is these were quite comparable, basically 93 versus 96% suppressed. Very few virologic non-response events, a few more in the CAB rilpivirine long-acting, but clearly non-inferior based on the primary outcome, which was proportion with virologic non-response. That's the primary outcome. The secondary outcome was proportion suppressed, and you can see again well within the 10% non-inferior bounds. This is actually the 4%, well I guess 6%, but falls in a very tight non-inferiority bound. So, the FLAIR study, very, very similar results. I think actually the percentages of proportion who remain suppressed were actually a little bit closer together in the FLAIR study. And this is looking at injection site reactions. So first of all, as you might guess, getting 2 ml shots, 1 in each buttock typically, there is going to be some injection site reaction. In fact, with the first injection, about 70% had some reaction, and that falls over time. I think in part it's because the injector got better, and in part because the patient was less tense and knew what to anticipate. What's important is that the most common by far is pain. And in terms of those of you who are really old, like me, there weren't like all kinds of nodules like with Infuvritide, nodules that persisted. Occasionally you can feel a nodule, but that was only about 4%. There's sometimes some induration, there's sometimes swelling, and sometimes there's severe enough pain to make it a grade 3, which means it interferes with your kind of activities of daily living, and you need to take a Tylenol or other pain reliever. But this is key. Patients that withdrew due to injection site reactions, 4 total, which is 1.3%. So very, very few patients withdrew due to injection site reactions. So remember that, well under 5%, just over 1%. So people will have injection reactions, but people tend to persist on treatment. You might point out to me that these are all people that signed up for an injection study. That's true. But I would argue, like in your clinic, you're not going to give an injectable to someone who doesn't want it, I don't think. You're only going to give it to people who are interested. The key will be making sure you've assessed people's interest. So if you actually look at the injection site reactions, these are patient-reported outcomes. In terms of, this is just asking the patient if the injection was totally acceptable, very acceptable, moderately acceptable, not at all acceptable. And this is at week 5, so that's a week after the first injection, or at week 48. And basically, I kind of lump very and totally together, and you get 90%. So most of the people found the injections either very or totally acceptable. And if you look at the pain aspect, again, it gets almost to 90%, that they're either very or totally acceptable. So again, and for the people getting the injection, remember in Atlas, all of them had experience with oral therapy for at least 6 months, and many for much longer than that. And you can see that the vast majority preferred the long-acting injectable. Okay. So every 4 weeks, that sounds like a lot. What about every 8 weeks? So Atlas 2M was a study of every 8 weeks. We don't actually have any data yet. It's possible that we'll see data very soon. All we have is a press release from August. But basically, in that press release from August, individuals who got injected every 8 weeks they met their non-inferior outcome. So I assume the non-inferiority margin was less than 6% confidence interval. So they met that margin, and then this is just a quote that I took directly from the report. Overall safety, virologic response, and drug resistance for every, it says 2 months, but it's every 8 weeks injectable were consistent with results from the phase 3 Atlas study that I just showed you. So that's what we know. We'll probably see the data sooner rather than later. Okay, so one difference between some of our switch studies and the Dolutegravir-Rilpivirine long-acting switch study is resistance was occasionally seen. The confirmed virologic failure was about 1% in the Dolutegravir-Rilpivirine arms across the 2 studies, FLAIR and Atlas. That's almost the same as the oral therapy arm. But 6 individuals on the Rilpivirine developed resistance, which is a small number. It's obviously less than 1% in both studies because over 300 individuals were randomized in each study. And there were some peculiarities here. They all were, 5 out of the 6 were from Russia, and 5 out of the 6 had a very specific subtype, A1 or A6. Some people call it A1, some people call it A6. These people in general had concentrations that were lower than the mean, if looking at concentrations over time, but they were in the range of the majority of individuals. So they didn't have substantially low concentrations. They were just lower than average. I think there's also a little difference between Atlas and FLAIR. In Atlas, if you look at, remember, Atlas, we don't have baseline genotypes from pre-therapy. These are genotypes done by the archive DNA assay. And you can see that 2 out of the 3 actually had pre-existing NNRTI resistance. So that's worth knowing. And then there was this one patient from Russia that had Dolutegravir in the past, and for some reason got switched to efavirenz abacavir 3TC. Not a common switch in my book. They didn't have any baseline RAMs looking at the HIV DNA at baseline, but when they rebounded, they actually had a 155H, which is a Dolutegravir mutation. So in people who were suppressed for a long time, I think there was like some suggestion of that there may have been explanations for resistance emergence, not exclusively the therapy. In FLAIR, patients were, remember, only suppressed for 20 weeks when they switched. They did have this baseline integrase mutation that's, it's actually a polymorphism, especially in subtype A1. But they did develop both integrase, here's integrase resistance mutations, and rilpivirine resistance mutations. So you can see maybe there's a slight difference between Atlas and FLAIR. Maybe it has to do with this subtype, which is very uncommon in the U.S., a little bit more common in Europe, though mostly in Eastern Europe, obviously. So we don't really know the whole story yet. But there was some resistance emergence. So I think you have to just kind of put that in the back of your pocket when you're thinking about this. There are practical aspects to using cabotegravir rilpivirine. I stole this slide from Chloe Orkin, who gives fantastic talks. If you want to watch her talk from CROI the past year, you do have to give a loading dose that's recommended with the first injection. So for the first injection, you actually get 3 mLs of cabotegravir and 3 mLs of rilpivirine. Maintenance, I already mentioned, the 1-month maintenance is 2 mLs. For the every 8-week maintenance, it's actually 3 mLs, so it's a bigger dose, not surprising. Rilpivirine, long-acting, requires a cold chain. Even though it's not liquid when it's shipped, it does require a cold chain. And then the injection is in the gluteus medius, which is up over here somewhere. So obviously you need a private place for injections, and there may be some issues in people that have cosmetic implants, and also injecting through tattoos is not recommended, though it's probably not a problem, but it makes it harder to evaluate that injection site. I don't know about weight gain in Atlas and FLAIR. I do know in the study of cabotegravir in uninfected men and women who were in a PK, large long-term PK study of cabotegravir injectable, there was no substantial weight gain compared to placebo. That's published by Rafi Landowitz. So unclear whether cabotegravir in the context of HIV will have a weight gain issue, but in the context of people without HIV, it does not appear to have a weight gain issue. A couple other challenges. Well, you have to be suppressed. At least that's what the package insert's going to say. And some of our patients who we'd like to use this in, maybe people that seem to come to clinic but can never get their medicines right, if you can't get them suppressed, at least won't be recommended. There is that lead-in oral cabotegravir and rilpivirine, so that's an issue. And then there's logistics, right? If you have a big clinic and 10% of people want injectables, well, that's 15 visits per day and 30 injections if it's a monthly injectable. So there are challenges. So I'm only 3 minutes over time, not too bad. So just summarize, I think integrase inhibitor-based therapy remain the standard, though maybe there's some caveats that we're thinking about women of childbearing potential and potentially this issue of weight gain that we're still trying to understand. I think 2-drug therapy for initial therapy is clearly non-inferior over a 96-week period as initial 3-drug therapy, but there are some caveats, maybe not best for rapid start, though I know there's a study of rapid start with the 2-drug therapy, clearly not for people with active hepatitis B infection, and probably not for people with very high viral load, but that didn't seem to bother the FDA all that much. I think 2-drug therapy for patients previously suppressed on 3-drug therapy without known resistance is very effective, either dolutegravir rilpivirine, dolutegravir lamivudine, and also boosted PIs plus 3TC are also quite effective in this setting, though, as I mentioned, we're trying to get away from boosters. And then finally, long-acting therapy with 2 drugs of cabotegravir and rilpivirine appear to be very comparable to 3-drug therapy in people who are either recently suppressed or have sustained suppression. There is resistance emergence in a very small number, that may be restricted to a single subtype, but I think at this point is incompletely defined. And then, as I mentioned, the FDA approval is delayed, but at least Joe Eron doesn't know how long it's going to be delayed. So that's my presentation. So let's go back to the pre-test questions that are now post-test. Which of the following is a potential advantage of two-drug therapy? Sustained suppression in treatment-naive patients with high viral load, that's A. Continued optimal therapy for patients suppressed on three-drug therapy who also have hepatitis B infection. C. Similar activity to continued three-drug in patients suppressed on three-drug TAF, that's C. And then non-inferiority but emergence of lamivudine or integrase resistance in 1% or more of the patients. Again, don't be afraid to vote. This is a test of me, not a test of you. This is how well I've actually been got my message across. And I'm resisting giving you more information right now, even though I want to. But you're doing a fabulous job. All right, looks like we lost a few people over the way, but I think that's probably it, huh? Come on, people, vote. There are 300 of you out there. Vote. All right. Let's go to the next question. Which statement most accurately summarizes the results of the phase 3 studies of COB plus rilpivirine long-acting? So A, the choice was long-acting was inferior but well-tolerated. Choice B was non-inferior, but there were more than 5% treatment discontinuations due to injection side effects. C, it was non-inferior and discontinuation due to injection side effects was uncommon, but HIV variants with resistance emerged on a small number of people. And then Cabotegravir D is Cabotegravir long-acting was superior to continued oral therapy, but patient satisfaction was poor. All right, outstanding. I don't know if I'm supposed to tell you how great you are, but you did a good job answering this question. Terrific. Okay, let's move on. So remember, this is the question and answer period. You can type your questions into the chat box, and there's a whole bunch, so I'm going to look at them in just a second. I just want to make sure I'm not supposed to do something else in a minute. Okay, so I'm going to answer questions, okay, so a lot of questions. So I will go up to the top of the questions. There's a question about whether we should do anything. I've never given a talk where someone doesn't ask this question. Please comment on whether anything should be done on low-level viremia less than 100 copies chronically. I like it better when my patients are less than 50 or 40 or 20, but I don't know of any evidence anywhere that shows that altering therapy in patients with persistent or intermediate low-level viremia, especially under 100, is of any benefit to the patients. There are a couple of very large studies. If you look at risk of virologic failure in very large populations, you can show that it's better to be less than 50 or less than 20 than greater than 50, but less than 200. But I also know there's unpublished data. There's a selection bias in publication where there are other studies that haven't shown any increased risk of failure. So I would not do anything except worry, which I'm good at. Patients who remain suppressed on Dolutegravir 3TC, even with a 184V, might DTG or other INSTIS prove durable suppression when used alone? A loaded question. Dolutegravir as monotherapy works, but not as good as dolutegravir with additional agents. There are studies that show well-documented virologic failure in some people with integrase resistance. And while most people do stay suppressed on dolutegravir monotherapy, the few that rebound have, I think of integrase resistance, especially dolutegravir and Bictegravir resistance, as kind of a lifelong toxicity. Not quite on the order of chronic pancreatitis, but really not good for you at all. So I would not do that. You're talking to the former 3TC evangelist. I know, based on multiple studies, that 3TC has persistent activity even in the face of 184V. I don't know why. I don't know if that's persistent antiviral effect. I don't know if that's fitness effect. But there are very good studies done, in the last century and in the early 2000s that unequivocally showed that 3TC had persistent activity in the face of M184V. So I would not do that. I would not use dolutegravir monotherapy. In contrast, boosted PI monotherapy, you do see failures, but they almost never select for resistance. There's a question about whether anyone is going to study Bictegravir FTC as a tenofovir-free option. I don't know. I don't think so. Another question that people ask is that same sponsor thinking about studying Bictegravir TAF as a two-drug option? The argument there is you wouldn't have to worry about hepatitis B. You wouldn't have to worry about transmitted 184V resistance. So that question has been asked. Again, I don't know the answer, but to me that one seems a little bit more likely. It's not really a question. It's really just making the point that if two drugs work, why give people three drugs? And I think that's a really good point. Someone might argue, well, if you studied 5,000 patients, maybe three drugs would be better than two. But that would mean the number needed to treat would be huge. So I think it's a good point. I think many of us are just not quite there yet. We're working on it. I certainly am very comfortable now in the switch setting to go to two-drug therapy with dolutegravir 3TC. It certainly has its advantages of fewer drugs, less drug exposure. So I appreciate the comment. So there's a question about whether I'm seeing substantial difference in weight gain for TAF versus TDF. I don't have enough patients to know that for sure. I do know that I have had patients on integrase inhibitors plus TDF-FTC, and when they went to switch from TDF-FTC to TAF-FTC, they gained more weight. Whether that's they might have gained weight anyway. People gain weight as they get older. I think our best data are the data from the advanced study, where in a randomized comparative way, people, both men and women, who got TDF with FTC and dolutegravir gained less weight than people that got dolutegravir TAF FTC. That's a published study. You can read about it in the New England Journal. You can look at it really carefully. It's all in South Africa. I don't know if every single patient was black, but I think virtually 99% were black. They're half women. It's a different place. It's a different diet. But I am quite convinced that some people gain a substantial amount of weight when they go to integrase inhibitor plus TAF and FTC. But I don't know why. And a great question is, well, can we change from Dolutegravir in people who gain weight? We don't know how to deal with this. I've changed some people who insisted that it was their medication causing them to gain weight. I don't know if that's the right thing or not. The other question is, do I use Dolutegravir in people who are overweight? Well, it turns out that while weight is one of the predictors of weight gain, it's not the strongest predictor. So I do think that second generation integrase inhibitors are our best therapy. So I use it. I explain to people that they might gain weight. I explain to them that they may have to be more careful about what they eat. They may have to exercise a little bit more than they usually do. But I still use it. A question about whether the long-acting agents have to be refrigerated then brought to room temperature before use. I'm probably not the best person to answer that question, but I do know that Rilpivirine it requires refrigeration, though I don't know whether that's for greater than a couple days or greater than a week, but it does require a cold chain. We'll have to ask a pharmacist to answer that. Can you use lidocaine gel over the area that for relief of pain? We've tried topical agents here. We've had multiple patients on long-acting injectable. The pain is really in the muscle. You're injecting into the muscle. People do have pain, I guess, when the needle goes through the skin. But the pain that I was talking about is actually pain that lasts for 24 or 48 hours. So that's kind of a longer-term pain that's due to injection in the muscle. Again, I think people over time learn how to deal with that, and they complain less of pain over time, in part because they learn how to kind of manage that, how to move a little bit, how to stretch, how to maybe put heat on it, or not go on a rowing machine, which one of my patients did. That was not a good idea. Next question is, what are my thoughts on a grace period between rilpivirine injections? Again, at what point do you have to do the loading dose again? And they're worried about people showing up late. That is an excellent question. In the study that I know best, which is the Atlas and FLAIR, I would have to look at the presentation for Atlas 2M. It was plus or minus 7 days. And after 7 days, you were considered outside of window. I don't know for sure how the therapy is going to be rolled out. I do know that patients will be given oral therapy for bridge if necessary. But I don't know what the package insert is going to say. You're just going to have to wait. I think if they have an oral therapy bridge, they probably won't need a repeat loading dose, but I think those are questions that will be really important to answer that I can't answer really well. Another great question, what about the long-acting tail of Bictegravir? So it turns out, and this is actually true for Rilpivirine also, but they have very long half-lives. A single injection of Bictegravir, you can detect a measurable drug 48 weeks later. And for women in particular that have reached steady state after their last injection, in some women you can detect measurable Bictegravir literally 72 weeks later. That's a long time. I think in the context of treatment, it's probably not a huge deal. I think we don't know exactly, but Bictegravir and Rilpivirine probably do decay relatively similarly, and that will be some data I'm going to be looking forward to when these drugs come out. For people who are in care and want to switch back to oral, not an issue at all. You could switch them directly to Dolutegravir TAF-FTC or Bictegravir TAF-FTC. You don't have to wait a certain amount of time. For people who discontinue and disappear, yeah, I suspect there'll be some resistance risk. Much probably maybe similar to what we saw with efavirenz, based therapy, where people were taking it intermittently. We would see selection of resistance because of the long tail of efavirenz orally. But it's an excellent question. I don't fully know the answer. If a long-acting injectable person is hospitalized, what do you do if you don't know their last injection date? I would switch them to oral therapy. Again, I bet the package insert will have some advice for us, but again, I would have no issue of switching them to Dolutegravir TAF-FTC or Bictegravir TAF-FTC as long as there isn't a contraindication to the nucleosides. And then the question would be, if you can't figure out when their last dose, do they need to get a loading dose again? And I think that is an excellent question, and I think it would depend on how long. But these are really great questions from really smart people, obviously. Next question, is it important if people are suppressed on 3-drug regimen but have a greater than 100,000 at baseline? There might be 1 million, I can't count all the zeros. And you plan on a 2-drug regimen? I think it doesn't make any difference at all. And the longer the patient's been suppressed, the more confident I feel about that statement. You might have gotten a gist from my presentation that the people that I am going to use on the long-acting injectable are going to be suppressed for more than 20 weeks. That's just me. The first people that I start using this in clinic are going to be people who are suppressed for longer than 20 weeks or 20 weeks of therapy. Those people obviously were suppressed for shorter than 20 weeks in the FLAIR study. But again, we'll get more confident about these therapies as time goes forward. That's not how the study was done, but that's my opinion. Do I feel that you have to use a DNA or archive genotype testing in patients whose genotype is unknown before making certain switches? No, I don't feel like you have to. I think if you have a good treatment history, you're in pretty good shape. I think if you're switching to a second-generation integrase like Dolutegravir or Bictegravir, and they have no history of failure on an integrase, you're in pretty good shape. I think the problem with the archive genotype is just it's good if it's helpful probably if it's positive. It's pretty much not helpful if it's negative. So I think if you're perhaps thinking about switching to a regimen that has a lower genetic barrier and the history is really unclear, that might be a situation where I would use it. I've ordered it maybe 3 times total. So I'm not a super big advocate of it because you end up learning what you already know, and maybe it supports a decision where you tell the patient, I'm sorry, you can't simplify because now I suspected you have these mutations and now I can see them on this test. Maybe it helps in that way. Can pharmacists be delegated to inject long-acting? The answer, I think it has to do with the state and the pharmacist license, but I think the basic answer is yes. Then what about patients who have been undetectable for 10 to 15 years, who are heavily exposed to other drugs in the 90s and early 2000s and have 100 responses? I've had 100% responses to switching those patients to TLD. TLD, I guess, is tenofovir, lamivudine, and dolutegravir. I think people who are suppressed for a really long time can be switched to almost anything, and they stay suppressed. But don't switch them to almost anything. Switch them to integrase-based therapy. And if you have someone that's been suppressed since 2000, I think they're very likely to be suppressed on 2-drug therapy. But, you know, if they got single and dual nucleosides, I would still probably use a single tablet 3-drug regimen. That's just my opinion. All right, that's all the questions. You guys have been great. Let me go through my last slides. The webinar will be on demand. Hopefully none of my family will watch it. And you can get CME credit. You can't get credit for both. Even though sometimes I'm not clear, you can't get credit for both. Though sometimes it might be good to go back and see what I said. Remember, evaluations will be posted by 5 p.m. today. Evaluations will be available. You will post their evaluation. But they will be available at 5 p.m. today, Pacific time. And you do have to do an evaluation to get CME credit. This is your question. When will the evaluation be available? If anybody gets this wrong, you're in trouble. I think we can move on. I think they got it. So I'm going to move on. And then just a couple other things. There's a webinar coming up in a couple weeks. Marion Peters is just great. How do we monitor people with HCV after they've been cured? That's a great question. I'd like to get on there and ask Marion Peters, do I really have to monitor these people with ultrasounds every 6 months for the rest of their life because they had a FibroScan that was F3? I don't think so, but that's the recommendation, and that's what I do because that's what Marion tells me to do. But get on there and ask her. And then our update courses, if you live in one of these cities or close, or you would like to take a week, a few days off and go to lovely Chicago in May, which is lovely in May actually, or Atlanta in April, which is also pretty nice, or Los Angeles or San Francisco almost any time, and New York, well, it's New York, it's great. So think about coming to one of these updates. I love them. They even invite me to talk at some of them, but not most of them.